In recent years, what can be considered a crisis in the mental health care system has arisen, following the closing of 6 of Chicago's 12 community mental health facilities, beginning in Rahm Emanuel's first year as mayor in 2012 due to lack of funding. The closing of these mental health facilities left thousands of consumers without access to mental health services. What happens to these individuals? While no empirical studies have been conducted to study the effects, experts have shared some common themes observed when these closings occur. First, patients are forced to switch providers but do not receive the same level of care when they do so due to interrupted relationships and lack of rapport between patients and staff. Additionally, caseloads of clients double or triple, forcing patients to seek care further from their homes to avoid month or even year-long wait times. This often drives patients to stop seeking care due to a further commute and consequently are more likely to end up in emergency rooms or even jail. Chicago's chapter of National Alliance on Mental Illness Executive Director Alexa James reported that since the closing, we've seen incarceration rates go up and we saw hospitalization rates go up within the communities that we work with. Cook County Sheriff Thomas Dart states that, "I talk to a lot of the detainees. They frequently tell me they shut down the clinic that I used to go to all the time. Now I don't have anywhere to go. I'm off my meds now. People who traditionally never would have been in a criminal justice setting are there now by default." The closings have perpetuated an already existing disparity in healthcare accessibility between the Southwest Side and other areas of Chicago. In a recent survey, 82% of Southwest Side residents have listed mental health as a top concern, but are met with only 0.17 licensed mental health professional per 1,000 residents, which is markedly lower than that of the near North Side and Oak Park areas.
I would say from the mental health community in general, there's a lot of concern and anger about it because mental health is a chronic mental health issue, the same as if you had diabetes or a heart condition, and they wouldn't cut off treatment for that group of people. And one of the other things that I think about is that people with severe mental illness, only about 20% of those people work. And of that, I think it's like 10% are able to maintain employment, so they don't have resources to get private insurance. So they rely on more public resources. I do. I loved my time in the community mental health system, and we were starting to feel some financial pressures at that point, but we were attached to Northwestern. So we had some other kinds of resources, and the finances weren't quite as tight as what they are now. But we had nurses, social work, psychologists, psychiatrists, OTs, mental health workers. So they would come in and they'd first be assessed by the intake team. They'd see a psychiatrist to firm up a diagnosis and get a better understanding of their medical needs. And then we would do an OT evaluation to identify what we could work on. It was truly an integrated team. Nobody was better than anybody else. So the hierarchy was gone. And I felt like we treated our patients with respect. And it was a family. I will say that there was a lot of irritation. And I don't understand how people don't see that people with mental illness need treatment and they need long-term treatment. I don't understand why they can't see that if you put a little bit more money up front, you could save money in the long run. I do think that this is where OT really has to step up and demonstrate that, look, we can teach them these daily living skills, and we can teach them stress management skills that they can implement when they're doing tasks that would hopefully keep them more on track. I think it's a great idea because it goes with this whole holistic approach that certainly as OTs we support. My fear is it's not pragmatic, that a lot of these centers, I don't know that they want to hire psychiatrists. Do they have the funds to bring in OT, PT, speech, whatever the clients need? And so I think at first there would be some focus on mental health, but I think it'll get pushed aside. And so again, if OT could get involved, if OT could get involved, because of our holistic nature, we can look at some of the psychosocial needs of the clients. But any client that's going in for primary care services, and that is great. Oh, and one other thing that I wanted to say that I think what could be really helpful is if there would be a way to get, this goes back to the advocacy, consumers more active in advocacy. In Massachusetts, in New York, in Pennsylvania, they have these consumers that are so active in advocacy. They have all these peer specialist programs where people with mental illness work for community mental health centers, psychosocial rehab centers. I would love to see that happen more across the country. And it is humbling to sit at the table with people with mental illness that are overseeing organizations and advocating. They do far more advocacy than I do. And it is very cool. It takes a little reorientation to things, but I think a lot of education. I think that we need to get some of these, the statistics from initiatives that have been done, implemented, and go to our policymakers and be able to demonstrate. Again, if you put more money up front, we can save money in the long run. Mm-hmm. That you may not be having may not be paying for community mental health centers, but you're paying in other ways, whether it's through state hospitalizations, through Medicare payments to skilled nursing facilities, or whatever it might be. So I really think we need to do that. I think that one way to do it, too, is to advocate for some of these non-traditional sites that have more of a psychosocial slant for the doctoral projects and experiences. It's a great way to get OT in and let people see what we can contribute. And then we can also start to collect some data on it. So I think it's sadly a long-term process, but we can't give up on it. And the other thing with doing some of this, Catherine Burson, who is a big mental health advocate, she's retired now, worked for the state of Illinois. She advocated that up at Trilogy, OTs get competitive wages. So OTs in the community tend to be paid less, and which is understandable. We get paid a lot of money, and a lot of these agencies can't afford it. However, it's a service that could reap a lot of benefits. Looking creatively, maybe you hire one OT and 3 or 4 COTAs, and that we need to show outcomes. It's great to talk about our programs, it's more powerful if we can show outcomes. So, yeah.
Members of these communities have objected to the closings by former Mayor Emanuel and have new hope that new Mayor Lori Lightfoot will support the reopening of the closed clinics. However, more must be done in order to reopen these clinics or find alternative ways to facilitate access to services across a wider population.